Okay, I will turn to our next speaker from China. And Mr. Hao Zhu, maybe on Zoom. Hi.
Thank you. Yes, can you hear me?
Yes, I can hear you and see you clearly.
Okay, thank you.
Please start your presentation.
Okay. And Ohayo gozaimasu. Good morning, ladies and gentlemen. I'm Hao, and a gastric cancer survivor from China. I'm supposed to join the conference on site, but there is something happened during my visa application that I cannot make the trip. Anyway, thank you very much for having me here, and I also feel very honored to be a speaker in this event to share my unforgettable experiences with you. So in the early 2017, I always felt a stomachache. At first, I didn't pay much attention to it because usually it happened before the dinner time, and after I ate something, the pain would be relieved. However, one night in early June, I felt so painful that I could not sleep well all the night. Then I realized that it was the time for me to see a doctor. The insurance company helped me register at the digestive department of Shanghai Ruijin Hospital, which is one of the top 2 hospitals in the city of Shanghai. The doctor who I visited was Dr. Jiang, who was a veteran of the area of gastroenterology and used to be the head of the digestive department. He asked me quite a few questions about what I felt and had me carefully inspected. He told me that usually gastritis might cause symptoms resembling what happened to me, and prescribed 2 weeks dose of a medicine made in Japan named Jeffernate tablets to me. However, he also told me that provided I was in the age of mid-40s, he could not rule out something more severe, and he seriously suggested that I should take the gastroscope examination. Fortunately, I took his advice very seriously, even though I knew the examination was very uncomfortable. Therefore, the next day, I went to the hospital to have the gastroscope examination without an anesthetic. The doctor told me that she saw there was a small, about 2 cm diameter, but severe ulcer in my stomach, and she had took some tissue samples to carry out the further pathological study. She urged me to take the medicine according to the prescription and came back 1 week later to get the final results of the pathological report. I did feel better after I took the medicine. 2 weeks later, when I ran out of the medicine, I decided to see Dr. Jiang again with the intention to have my stomachache cured for good. When I was waiting in the reception room, I suddenly remembered that the pathological report should have been due. However, when I got the report, I felt sweetened at the sight of the red seal on top of the paper, which read signet ring cell cancer. I Googled the term and found out that it is a kind of highly malignant stomach cancer. Dr. Jiang read the report and told me that it should be treated by operation. He went out of the room and walked around to see which surgeon was on duty that day. After a while, he came back and told me that I was lucky as Dr. Zhu was there. He is among the top experts in curing gastric cancer. Then I was referred to Dr. Zhu by Dr. Jiang. After carefully reading the report, Dr. Zhu told me that the cancer should be in early stage according to its size and appearance. And if it was to moved by operation, there would be very good chance that it would not return in the coming years, and I could survive for more than 5 years. He asked me not to be too worried about my disease and told me that he had performed such kind of operations more than 1,000 times, and a lot of patients had been cured. And he concluded that I should be hospitalized immediately and took some further examination to check whether the cancer had shifted or spread. If not, the operation was scheduled on 5 days later. So Dr. Zhu contacted his colleagues to help me with the hospitalization, and the process was smooth, and I was sleeping in the hospital the next night. I took the CT and the blood tests, and the results were good for operation. The next 2 days were weekend, and I was allowed to go back home to spend the weekend with my family. And I had the operation in the morning of the next Tuesday. Although it took 3 hours long, it went smoothly. Nearly 2/3 of my stomach had been cut, and 15 lymph nodes nearby had been removed. I spent 10 days in the hospital after the surgery. The first 2 or 3 days were very difficult to me, as I could feel the pain without the anesthetic. However, I could also feel that I was getting better and better day after day. Dr. Zhu came to see me several times, and he told me the good news that the cancer hadn't invaded other parts of the body. His colleague from the oncology department also joined him to determine the treatment after the surgery. It was to take a Japanese medicine named S1. After 4 weeks since the surgery, I went back to the hospital to see Dr. Zhu. Although I recovered very well, I did feel upset that I was faced the chemotherapy, as I knew it was related to bored, vomiting, nausea, and etc. Dr. Zhu explained to me very patiently what the medicine's ingredients and the potential side effects, which made me feel much more calm. And I was lucky enough that the bad situations didn't happen to me at all. I took the medicine for 8 rounds, and after half a year, it seemed that I was getting rid of the cancer of all. So that's my story, ladies and gentlemen. It may not be very impressive to you. However, it is an unforgettable experience to me. I was lucky enough that I met the best doctors in Shanghai. Thus, I didn't hesitate for a second when Dr. Zhu invited me to join the conference to share my experiences. So I think it is very meaningful, and I sincerely wish the conference a success. Thank you very much. That's all.
Thank you very much, Mr. Xu. I'd like to take this time to invite to the podium the speakers, as they're able, as well as bringing together our panelists, and then open this session up for questions, because I'm sure there will be many. I definitely want to, especially want to voice my appreciation for those patients sharing their journey. I think that all too often, surgeons in particular may not always listen and hear what life is after we discharge patients. Thank you. Okay, we are now open for, and is Franco Ravello, is he wired in or no? He couldn't, okay. No, I thought it was going to be virtual, but okay. All right, why don't we go ahead? First question. Well, how about I start? As a policy, I think some places insist on patients talking to others who've been down that road before. As you indicated, Steve, the talking to someone and the gratitude that you get personally, that warm feeling, is important, and it's sort of like passing it or paying it forward to be able to then help others along the journey. And I know Debbie's Dream does this. There are some other organizations that do. But it seems that the education really needs to happen to the surgeons, because they're the ones who are ultimately going to do that. And I was wondering if you had any suggestions on how to best do that.
Well, thank you for that question. When I was meeting with the surgeon at the time, I felt that they wanted to move me on and go to the next phase and go to my oncologist. So, and then once the oncologist finished seeing me after five years or so, they said, I'm done. I'm just like everyone else. And so I felt kind of alone in this whole thing. I hadn't talked to my surgeon after until I had to come back and get my gallbladder removed. But I think if I would have had some type of communication early on and just to know that I wasn't going to really be alone, but I just felt that, this is a while ago though, I know things have changed, and I know in hearing from other doctors recently that there's more follow-up, but I just didn't feel like anyone really cared. I mean, I know they cared, but they just let me go. So I think something initially, right at that initial stage, would have made me just have more, I would have felt more comfortable.
Dr. Coburn.
Hi, Natalie Coburn from Toronto. Thank you for sharing your stories, and Mr. Zhao on video as well. I want to follow up on what Dr. Mansfield said, because I think we have an excellent opportunity here. I was just noting the immense amount of leadership that we have in this room from IGCA. So how can we do better? What do we as physicians, and especially surgeons, need to do better? Is it more education? Is it more printed material? And how do we do this better? Because I know when we have these conversations in clinic, I think you get past the biopsy shows cancer, and you can probably spend an hour and a half explaining things, and somewhere in the back of patients' minds, things just click off. So are we doing too much information at one time? How can we format this better?
So, hi, I'm Ekaterina. I am a stomach cancer survivor, 12 years. I am also the co-founder and vice chair of My Gut Feeling Stomach Cancer Foundation of Canada. Thank you so much, Dr. Coburn, for your question. I mean, I think what you pointed out is very true. The first thing when you hear is you have cancer, your life flashes before your eyes, right? On one hand, you want to deal with the cancer, get it out as quickly as you can. But on the other hand, you're overwhelmed with the amount of information. So absolutely, having more than just a conversation, having guidelines for patients, having written verbal material, as well as YouTube videos and other resources that are culturally specific. So, if you have a Canadian patient versus if you have an Asian patient, the way you may approach and cope with the surgery may be different, right? Involving caregivers is absolutely very important as well, right? Because the patient may not hear the information on day one, but it's the caregivers that will go through this journey with the patient throughout. So really having patient guidelines and multiple media, multiple language that are culturally specific. Also giving the information about advocacy groups at the beginning. So as Steve pointed out, having those peer mentors is absolutely crucial throughout the journey, right? So I remember my surgeon essentially said, you're gonna lose, about 10% of your body weight and then you'll be fine after the first year. But that's simply not true, right? So the lived experience is absolutely crucial. I can tell you that 12 years later, although I am well and I'm healthy now, I have a new normal, right? So what my surgeon told me at the beginning, although was very reassuring and great, it's the lived experience that I know now that it is a new normal and a new change in your life.
Yeah. I think one of the things I try to do at that first visit is, I don't always remember, but I encourage people to actually record it. So they have a family member there, and I tell them, you're going to have 3 versions, your version, their version, and then a recorded version. And then you'll both interpret that differently, but then develop the questions that we can come back and try to answer. But I think what I'm hearing from you is it's more of an iterative process, and I think I hear that from you as well, because these operations in general are not emergencies. They're important. So, Professor Casado.
Yes, please, I want to hear from you, because the focus nowadays is shifting regarding the follow-up, because many years ago, we, the surgeons, were the guys who followed the patients in the first 2 years, each 3 months, and then each 6 months. But from 5 years on, the oncologist came in. This is maybe a burden for the patient, because he has to come to the surgeon and then to the oncologist, and also regarding the information, because sometimes the way to look to the disease is not the same. So I want to hear from you, the patients, what do you think about being followed by the surgeon, by the oncologist, by them too? Is it too heavy? You have too many things to...
Well, I think I'd prefer never seeing my surgeon again after the first visit. So it's not that I didn't like him and appreciate him, but I didn't want to go back. I think that I don't know. I was just so happy to move on, but it was also overwhelming in the very, very beginning that I didn't hear anything really. It all came in.
I basically follow up patient till 10 years after surgery, because until 10 years they may have some risk of recurrence. And also many medical oncologists, they don't have much knowledge about the physiology of digestive tract function and sequelae of the gastrectomy and so on. So I think it's better for surgeons to follow up the patients. And if the patient have some recurrence, then the medical oncologist can take care of some part of that follow-up. But maybe dietitian and some other colleagues can, well, joining a team and follow-up can be good, but maybe not every patient it is possible to be followed up by your teams.
Yeah. Ekaterina, I think. Yeah. Ekaterina, also, you had another comment.
I was just going to echo what you're saying, right? It's about having an integrative team, right? It's we realize that surgeons only have a certain amount of time to spend with their patients, and you guys can't do it all, right? So, for example, I'm a physician assistant. I work in medical oncology, so I have specialized knowledge in that department. So I'm able to share that knowledge and spend that time with my patient, whereas my supervising physician might not have the luxury of that time. So again, having a team of dietitians, social workers, right? So you're impacted financially, right? Your identity is impacted. Psychosocially, so a psychiatrist may be part of that team, the medical oncologist and the surgical oncologist. It shouldn't just fall on one person. That knowledge should be shared amongst the team, and that team should look at the patient holistically, not just from a surgical standpoint.
Mm-hmm.
Yes, Dr. Sasak, I'm not a medical oncologist. I'm not here to against you. Yes, as Katie mentioned, surely is a team approach. But before I make some comment, I would like to express my real gratitude to our patients, panelists, because mostly a patient, you do not want to expose your cancer. So whenever we have some educational program, TV program, difficult to invite, but this is how we appreciate yours. And back to that follow-up, we do. Please let me tell you, in Korea, Seoul National, we do, yes, surgery, surgeon, but chemotherapy together. So both because of the recurrent period, and then a medical oncologist to follow up the chemotherapy. But after finish the chemotherapy, patient do not have to come duplicate. So then medical oncologists refer the patient to a surgeon. So we follow up to 5 years. And then if patient recur, we refer back to a medical oncologist. But this is a usual traditional way, yeah. And but also there's now application virtual things. So when patient discharge, they are worrying about small things happen. So my outpatient clinic next visit is 2 months later, but we can be connected through application. Just so how much you eat, our nutritionists measure the calorie. Oh, today you achieved something, your body weight, how much. So this is what we will improve for our patient care.
Okay, thank you. No, I could not agree more. It's a team. It's the dietitian, it's the, I work with the nurse practitioner, but also the clinic nurse, and all of those people work together. I think you touched on something else that is important, is oftentimes patients will travel a distance, and so telemedicine for just some of the follow-ups and checks and make sure that if they need to come back, they do, but visiting us is not a burden to them because there's the expense, the time, and you know, it's trying to find that balance. I think that's important. I know you had a question.
As a chairperson, I think education for patient is important, and so I am challenged to create an information booklet and website. And so I want to ask a question for Steve, Hao, Katie. After the surgery, what did you realize you should have asked?
Honestly, it was almost better for me at the time not knowing anything about how bad it was going to be. Okay, so everything was more difficult than I thought, and so mentally getting through this, I think the psychological part and the stress of all that, and that's why I didn't necessarily need to know exactly all the pain and suffering I was going to go through. I just need to know that I could make it. And that's why those mentors or those people that I had in front of me were so important to me. And just the little things on a day-to-day basis. So I may not be the best to tell because I really didn't do a lot of research. I didn't even know what a spleen did when I was in the morning of my surgery. So I'll pass it on to her.
I think that's curious. You said you were told the morning of surgery what was going to happen to you. And I have a real problem with that with surgeons. I don't know about the other surgeons in the room, but if that happened at my institution, you wouldn't last there very long because patients, you can't digest that when you're sitting there, with the bunny hat on and the, booties and naked. It doesn't work.
It added an element of stress that morning. I was already poked a couple times and just feeling that my luck wasn't going so well that morning, and then when I saw that, I hadn't done any research prior, and so I should have been told more.
Well, you raise an interesting question, and I don't think that people necessarily feel empowered to do this, but until you get sedation, you can always say no. Say, whoa, you've changed the deal here. I need to think about this, and if the surgeon has any if they're any good, they should respect that. So
it was the one thing in my life where I actually let go and let God kind of take over. And so I had to choose which hospital to go with, and Stanford, as I joked, was one I always wanted to get into. So I said, I'm going to trust these people and what they're going to do, and they're going to tell me, and I will just put my head down and do it. And I mean, it worked out, but it didn't go as easy as I planned.
Sure. Dr. Zhu?
Thank you.
Okay, I just want to something that the Mr. Zhou Hao is my patient. Yeah, he was very lucky because he suffered early cancer, so very successful. The gastrectomy be performed in the 6 years ago, and so he can survive very better up to now, yes. But unfortunately, in China, you know, the most of the cases when diagnosed is almost belong to the advanced stage or far advanced stage. So usually, maybe I think it's the big difference between the Western and Eastern people. So in the Western country, maybe the doctors will tell the family or patient, how about your disease? Maybe you are in the stage 4 or some late case, and you can survive how many years? Maybe half year or 1 year or 2 years, maybe, I don't know. But in China, the patient family usually are reluctant to let patients know their disease. Yeah, so if you want to give the explanation to the patients, to their family, sometimes it's difficult. So we usually just give them a very easy introduction, or it's a very simple introduction to their disease. So it's the big problem because the different culture and different religions between the West and the East.
Can I? Yeah, it's actually the almost same condition in 1980s in Japan, but it's now completely different. So we have made some effort to change the society, and because even the stage 4 patient can get benefit of knowing the truth. It's their own lives. They can decide by themselves, and we can help mentally, spiritually as well. So I saw many patients when I was a young doctor dying without knowing the correct diagnosis, but all of them had very much anger and desperate and not happy. But seeing the patient who knew everything and go to the heaven, they are much more happy.
Yeah, I think you're right, Mitsuru. One of the things that I've seen, especially from the Middle East, is for a female patient usually being intercepted by the males in the family saying, no, you can't tell her she has cancer. And then once they finally leave the room and I'm working with the translator and the patient, she says, don't tell my family I have cancer. They can't handle it. And so, you know, most patients know. So, but thank you. There's a question we have coming in that actually ties into some of this, and then Natalie will go to you. It says, in my father's case, some doctors are suggesting to start immunotherapy, Novemilab. And some doctors are suggesting not to start immunotherapy, as his PD-L1, MSI, and HER2 are all negative. How do you make decisions in such a case? And I think next session may help with this more, but I think it's, you touched on the idea of getting one story one place, another story another place, and you know, I know it's difficult for patients, and I think it comes down to matters of trust. But how do you guys?
Yeah, I mean, I think immunotherapy is definitely a hot topic, especially in the case of CPS 0 to 5. So we know that immunotherapy works best in CPS 5 and greater. So really, I think it comes down to patient preference, right? So we know that adding immunotherapy is a time commitment. So commitment being in the chair. Now, you know, the medical oncologist may talk to you through informed consent, and as we know, so similar to surgery, it's about a 25-page document of informed consent, and on page 25, it'll say, well, there's a 1% chance of death, and that's always on page 25. So, you know, it all comes down to patient preference, patient age, patient comorbidities, right? Are you willing to sit in that chair for a potential additional chance? You have to trust your team, you have to know yourself, you have to know your values and your preferences.
Thank you.
Thank you. I'm kind of following up on this. At MD Anderson, when someone asks for a second opinion, how do you advise them? Because I know there are a lot of patients who feel that they cannot, that they should not question the judgment of their team, that it may disadvantage them in some way, and obviously time is of the essence. So what, I know Dr. Mansfield, you have some thoughts on this. What are your thoughts on second opinions?
Oh, you're right, it does come down to trust. Back when I was initially doing HIPAC procedures, I would encourage people to go talk to other physicians. And I actually picked up and made appointments sometimes, because with people I knew, people I trusted. But I think one of the challenges with that is too often physicians allow their ego to get in the way of someone having a second opinion. I mean, if I tell a patient what I think is the right thing for them to do and they choose to go somewhere else, that's their choice. I mean, it's most important. I tell them it's most important to me that they feel comfortable wherever they're being treated. And that may be an anomaly, but somehow we need to make sure that, maybe it was best said by a patient's mother many years ago who came from another place and said, in my place, the patient exists for the doctor. Here, the doctor exists for the patient. And I see more and more of that, but we need to somehow get that to permeate more. Professor Brennan.
Maybe I can take it from 40,000 feet, what I've learned over the last 40 years. Most of life is about expectations, marriage, children, all those things. And the surgeon's the one that has to set those expectations. And you set the expectation when you walk into the room. And if you walk into the room with a chart in your hand and say, how are you doing? You've already lost the game. If you come in and sit down in front of the patient, this addresses the family problem, regardless of the nationality. And I was taught that 3 decades ago when I sat down and asked the patient directly with the family arrayed behind me, Mr. So-and-so, what do you understand? He said, I'm fine, I've got cancer, but my family doesn't want to talk about it. And I think if you ask the patient, what is it you expect of me? Oh, you're the surgeon. No, take a step back. But if you walk in with the chart, or today walk in and sit down at the computer, you've already lost the game. So I think we have an obligation to not forget that we're supposed to deliver expectations. I understand this is the toughest chance you'll have. I understand that you're not going to learn a lot. Please write down what you want. Anything my nurse assistant cannot answer, I will answer. Here's my phone number. There are lots of strategies that we can do a lot better than we've done. And we're going backwards with this idea. The computer is the chart. And so you sit down. And the data is clear. In the US now, 45% of the time the doctor spends in the room, he or she is in front of the computer. A guaranteed recipe for disaster in my mind.
Yeah, that's a great point. I try to only use the computer when I'm showing the patient something, but other than that, it doesn't exist. So I think it's a great point. And you also said something that I think is also critical. Having patients write down their questions, and because they may think of them at 3 o'clock in the morning. I encourage patients to get a spiral-bound notebook. Wake up in the middle of the night, write your question down, go back to sleep. Because if they don't, they'll forget it. Yes, Han.
Yes, in this first session, especially Mr. Howard Chu, he was lucky. I want to emphasize symptom. This is a Korean audience, Chinese audience, Japanese audience, American audience. First thing is gastric cancer does not have a symptom. So when it comes, it may be too late. So for Japan, Korea, because it has a screening, you have to do that. But other countries, if you have any symptom, just visit doctor. And second, I have to confess, I did not realize how Mr. Mellon had gone through the pain, because until last year, I had a cholecystectomy. It was a laparoscopic surgery. I always told my patient, oh, laparoscopic gastrectomy, it will be fine. But cholecystectomy is so painful. Yeah. Doctor tell me, you can discharge tomorrow? No, I want to stay 1 week. I need a painkiller. So this is what I want to tell. This is the morning 4 sessions. We want to experience patients' pain together. Thank you.
Thank you very much. And thank you for this session. Thank you all for participation. We've got to move on to the next session, which starts now. Thank you so much for being here and for sharing your story. Sure.
Chairman, maybe here.